Hey everyone, my name is Ashley and I'm a fourth year veterinary student at St. George's University and I am currently doing my clinical year at Virginia, Maryland. And my NAVLE examination is coming up very soon. It is going to be October 18th. So I figured I'd do a few live streams so you can join in and study with me. Today I'm just going to be doing some NAVLE prep flashcards for the next hour. So if you want to join in, please feel free to do so. But I did buy a NAVLE prep set from Momentrix, and honestly, it's been phenomenal. I really enjoyed it. So today I'm just going to be focusing on canine stuff just because there is a lot of canine on the veterinary license exam. So first up is going to be cardiac arrhythmias. So for the pathophysiology, an arrhythmia is any heart rhythm that is not a normal sinus rhythm. Arrhythmias can occur secondary to structural heart disease, electrical conduction abnormalities, or can be induced through extracardiac diseases. These can affect cardiac output, which can result in clinical signs that you see. The most common arrhythmias seen in dogs are atrial ventricular block, atrial fibrillation, and ventricular premature depolarization. So some of the clinical signs and symptoms that you can see is syncope, exercise intolerance, and kind of the clinical signs showing congestive heart failure if structural disease is present. To diagnose cardiac arrhythmias, you do see it on electrocardiograms. And to treat these, it's arrhythmia dependent, and there's quite a few cardiac drugs that we can use, or a pacemaker could be indicated. It really does depend on what type of cardiac issue it is. Next up is going to be dilated cardiomyopathy. And I actually just had a case on this week, so this is pretty neat to see. The pathophysiology of dilated cardiomyopathy occurs when there is a loss of myocardial cells, either in number or in function, and a subsequent loss in cardiac contractility. DCM is a heritable disease in certain breeds, like Dobermans, but can occur secondary to viral, dietary, and chemical causes. DCM is usually progressive and results in congestive heart failure, auscultation, a systolic murmur at the left heart base, exercise intolerance, and syncope and congestive heart failure are all clinical signs of DCM, which is dilated cardiomyopathy. To diagnose this, we use an echocardiogram to assess the chamber dilation and the electrocardiogram to identify concurrent arrhythmias. To treat congestive heart failure, we use diuretics and positive ionotropes and ACE inhibitors. The next flashcard is cardiopulmonary arrest. So this is the cessation of cardiac and respiratory function. This can occur secondary to anesthetic drug overdose, a consequence of severe systemic illness, metabolic disturbances, or from end-stage cardiac or respiratory disease due to hypoxia. Some clinical signs that we can see with cardiopulmonary arrest is arrhythmias that include asystole, pulseless electrical activity, sinus bradycardia, ventricular fibrillation and pulseless ventricular tachycardia, cyanosis, and lack of a heartbeat and respiration. To diagnose this, we do an electrocardiogram and thoracic auscultation. To treat this, we can do CPR resuscitation, but sometimes it's not as effective. We can also do endotracheal intubation, oxygen supplementation, epinephrine, and defibrillation. Next up, we have cardiac septal defects. The pathophysiology of this is ventricular septal defects are congenital cardiac defects that occur more commonly than atrial septal defects in dogs. Small defects may not cause clinical disease, but large defects result in shunting between the adjacent heart chambers, leading to volume overload and pulmonary hypertension. For the clinical signs, there is usually a systolic murmur may be the only finding, or you can see cyanosis, lethargy, exercise intolerance. To diagnose cardiac septal defects, we use the echocardiogram to visualize the defects. To treat, small defects require no intervention, and usually for the larger ones, we use a transcatheter closure, which can be attempted, but it's not always successful. So it just depends. So this next one is definitely going to be on the NAVLE for sure. It is patent ductus arteriosus, which is PDA. This is a congenital defect that occurs from a failed closure of the fetal ductus arteriosum, resulting in left to right shunting of blood from the aorta to the pulmonary artery. It results eventually into left-sided congestive heart failure. Volume overload causes pulmonary hypertension or right-left shunting, which is the reverse PDA. So for the clinical signs of PDA, which is patent ductus arteriosus, there is usually a continuous murmur in puppies with bounding femoral pulses, and reverse PDA shows cyanosis and exercise intolerance. To diagnose this, you use an echocardiogram and angiogram. And then to treat it, usually surgical closure is needed. Then we have pulmonic stenosis. This is definitely going to be another big one on the exam. So pulmonic stenosis is a common congenital defect in dogs with a brave disposition, such as the boxer and bulldog. And it's characterized by dysplasia of the pulmonic valve that causes a right ventricular outflow obstruction. And also there's an increased right ventricular resistance, which eventually results in ventricular hyperplasia and eventual right-sided heart failure. So the clinical signs for this one is a systolic murmur is heard over the left heart base, and there is exercise intolerance and ascites. To diagnose pulmonic stenosis, you'd use an echocardiogram again and angiogram, just like you do with PDA. And the treatment for pulmonic stenosis is the balloon valvoplasty if it's a mild stenosis. And this is, again, typically seen in bulldogs and boxers. Next up is aortic stenosis. This is definitely going to be another big one on the exam. Stenosis can occur secondary to the presence of a fibrotic ring within the aorta, either at the level of the valve, below the valve, or above the valve. Stenosis results in the outflow obstruction of the aorta and decreased cardiac output and ventricular hypertrophy. Ventricular hypertrophy results in myocardial hypoxia and ventricular arrhythmias. The clinical signs of aortic stenosis is left-sided systolic murmur, exercise intolerance, syncope, and unfortunately sometimes sudden death even. To diagnose this, we do an echocardiogram again, and to treat, The aortic stenosis is with beta blockers and surgical correction. For congestive heart failure, this is also another big one that's going to be on the exam for sure. This is a syndrome that results from multiple disease processes that decrease function of one or both ventricles, which are unable to pump blood effectively. This results in blood backing up behind the chamber and subsequent effusion due to increased vascular volume. Pulmonary edema is seen in left side heart failure, while ascites is seen in the right side heart failure. You absolutely have to know the difference between the two. For the clinical signs of congestive heart failure, you can have tachypnea, coughing, exercise intolerance, abdominal distension, and plus minus a murmur. To diagnose this, you can do a thoracic radiograph or an echocardiogram again. To treat, you can use diuretics or positive ionotropes and ACE inhibitors. And lovely heartworm disease. It's never a good one to have, but this is always talked about, and it is such a big issue in the United States, so this will most likely be on the exam as well. Heartworm disease is a parasite that affects the heart chambers and great vessels. The parasite is transmitted through mosquitoes, which are required for the larva to reach the infected L3 stage. The larvae grow into adult worms over weeks or months, and clinical signs appear as the adult worms occlude blood flow through the heart and lungs and incite inflammations. For the clinical signs, usually there's no signs early in the disease, but it does progress to coughing, exercise intolerance, cyanosis, and dyspnea. To diagnose heartworm disease, you can do the serum antigen ELISA or the NOTS test to ID megafilaria. And then to treat, we typically use doxycycline and also an anti-microfilaria prior to the melarsoline. And keep in mind that you cannot use melarsoline in cats. So if your patient is a cat on the exam asking about how to treat heartworm disease, do not pick melarsoline. Next up is systemic hypertension in dogs. So hypertension is just an increase of vascular pressure. Primary hypertension is very rare in dogs, so it's usually always secondary, and it can be due to renal failure, which is the most common cause. Um, with the dogs who have been diagnosed with Cushing's disease or diabetes mellitus. Clinical signs are related to end organ damage to organs with large arterial density. So, clinical signs of systemic hypertension is end organ damage, such as retinal hemorrhages. To diagnose this, you can do direct or indirect measurement of blood pressure, and to treat, you can do hypertensive drugs and also diuretics. Next step is going to be pericardial effusion. I've actually seen quite a few vet prep questions about pericardial effusion, so I think it's probably pretty important. But this is the accumulation of fluid in the pericardial sac that is secondary to another disease process. Common effusions include exudate from infections, transudate, blood, and neoplasia. Clinical signs, it's often mild until it progresses to exercise intolerance, weakness, and tachypnea. But to diagnose this, you can do thoracic radiographs or ultrasound and cytology of the pericardiocentesis. So we can pull blood from the heart. And to treat this, you basically find what the underlying disease is because usually there is something contributing to the fact that there's extra fluid around the heart. Mm. So another one is PPDH, which is the peritoneal pericardial diaphragmatic hernia. It is definitely a very long word, but this is basically a defect in which the abdominal cavity communicates with the pericardial space, and abdominal contents may reside in the pericardial sac. So PDH is most often a congenital defect, but rarely occurs secondary to traumatic injury. It's frequently an incidental finding, and signs may not be specific. To diagnosis, usually we find it on radiographs and on ultrasound and advanced imaging like CT or MRI. To treat, usually early surgical intervention is needed, and repair of the diaphragm is recommended to reduce potential for adhesion formation within the pericardial sac. Next up is the valvular degeneration. This is a suspected hereditary age-related change that most commonly affects the mitral valve. Valvular degeneration results in insufficiency and causes mitral regurgitation that progresses to decreased outflow and congestive heart failure, and then also hypertension through activation of the renin-angiotensin aldosterone pathway. Clinical signs of this: murmur over the affected valve, cough, dyspnea, exercise intolerance, and abdominal distension. To diagnosis, we can do thoracic radiographs and echocardiogram, and then treatment is targeted at congestive heart failure. Well, so far we have gotten through about 13 flashcards, so I'm going to take a slight break. If you do have any questions throughout the video about how I'm really studying for this exam, please let me know. Even if you're watching this later and still have questions about what I'm doing, you can ask me. Been doing kind of a mix of flashcards versus timed exams with VetPrep and studying with friends as well. I'm kind of nervous for the exam. I feel like I know nothing, but I feel like every vet student feels the same way. And we are preparing ahead of time for the exam, which is good. But the next one is going to be diabetic ketoacidosis. I actually just had a case of this in the emergency room last night. And it is a consequence to unregulated diabetes mellitus due to the animal relying on the oxidation of fatty acids for energy. And ketoacids are byproducts, and their accumulation causes metabolic acidosis and electrolyte disturbances and azotemia. So untreated DKA is extremely life-threatening, so usually these patients have to be hospitalized. And clinical signs of this is lethargy, anorexia, vomiting with concurrent hyperglycemia, and dehydration. The diagnosis, usually you will see a hyperglycemia on the blood work, and usually you'll see ketonuria in the urine. To treat this, we usually do IV fluid therapy and administration of insulin products to normalize the serum glucose. Next up is Cushing's syndrome. This will definitely be on the exam. Hmm. Yes, it is the overproduction of glucocorticoid hormones. This can be triggered by an increased adrenocorticotropic hormone released from the pituitary or increased production by the adrenal glands. It is usually the pituitary dependent, but it can also be iatrogenic, which is seen secondary to chronic steroid administration. Some clinical signs of this is polyuria, polydipsia, hot-bellied appearance, alopecia, excessive panting, and the calcinosis cutis. To diagnose this, we can do the low-dose dexamethasone suppression test, and the medication for Cushing's disease is trilostane and mitotane. Surgery is rarely pursued because it really doesn't help the situation because it's an underlying endocrine disease. And next up is Addison's disease, which is the hypoadrenocorticism. So you definitely need to know the difference between hypo and hyperadrenocorticism. But for Addison's disease is a failure of the adrenal glands to produce the mineral corticoid and glucocorticoid hormones. This causes significant electrolyte disturbances such as hyperkalemia and hyponatremia. So high potassium, low sodium, and glucose disruption. So atypical Addison's occurs if only glucocorticoids are low. Some clinical signs of this is usually an Addisonian crisis, which is seen on the physical exam and blood work. So usually you'll see hypotension, hypoglycemia, bradycardia, and non-responsive to intermittent gastrointestinal distress and lethargy. To diagnose this, we can do the adrenocorticotropic hormone stimulation test, and to treat, we usually do mineral corticoid and also glucocorticoid replacement. And there is like a specific flashcard on Addisonian crisis. So this is an emergency presentation of unregulated Addison's disease. So deficiencies in mineral corticoids result in hyperkalemia, hyponatremia, and hypochloremia, while deficiencies in glucocorticoids leads to hypoglycemia accumulating in circulatory collapse. So some clinical signs, we can see a collapse of the patient, bradycardia, hypotension, weakness, vomiting, and diarrhea. To diagnose this, we usually use the clinical signs and electrolyte imbalances. Then we can use the ACTH stimulation test for a confirmation. And to treat, we can do fluid resuscitation, administration of dexamethasone, and long-term steroid replacement. Definitely, this one will be on the exam, which is the hypothyroidism in canines. So, hypothyroidism is due to a decrease in production of thyroid hormones, which is T4 and T3. This occurs due to atrophy or immunological destruction of the thyroid gland. Clinical signs are related to lipid metabolism presenting across multiple systems, including CNS, skin, and GI. Some clinical signs that you will typically see with hypothyroidism is weight gain despite normal calorie intakes. And you also could see symmetrical flank alopecia, dermatitis, and medexemia. And also, as a side note for hypothyroidism, you will never see PUPD. with hypothyroidism. So if that's an answer choice, do not pick that for hypothyroidism. The diagnosis, usually you'll see a decreased T3 and T4 with elevated thyroid stimulating hormone, which is TS8. And you could also see an increased thyroglobulin. And then to treat this, usually use synthetic levothyroxine. Next up is the gallbladder mucocele. This develops when bile contains high amounts of mucin, which accumulates within the gallbladder. Obstruction of the gallbladder can occur with this and results in continued distension in wall ischemia and necrosis and bile peritonitis. Some predispositions include hypertriglyceridemia, endocrinopathies, and gallbladder dysmotility. So some clinical signs of gallbladder mucocele is vomiting, anorexia, abdominal pain, plus minus jaundice. To diagnosis, usually we see an elevation in serum liver enzymes such as ALT, ALP, and bilirubin. And the ultrasound shows a classic kiwi appearance. So this does have a very specific ultrasound appearance, which might be on the NAVLE. And usually surgery is recommended. There's usually limited success with medical management. Next step is cholangitis. So this results from inflammation of the biliary tree. Usually we see neutrophilic and associated with bacterial infections from enteroportal circulation, which are the most common. So inflammation can result in the biliary tree obstruction. So it is definitely important to treat this if you see it. But clinical signs for this is fever, vomiting, diarrhea, abdominal pain, jaundice, polyuria, and polydipsia. And to diagnosis, usually we see hyperbilirurimia in the blood work and also an elevated ALT, ALP, GTP, and ultrasound changes that are supportive. But the only definitive diagnosis that we can do is a liver biopsy. And to treat this, we can use antibiotics and urushiol and symptomatic therapy. Next up is the parvoviral enteritis. So parvovirus is definitely going to be on the NAVLE exam, so it's another big important disease you want to know a lot about. But parvovirus in canines is a highly infectious viral infection that infects rapidly dividing cells, such as the intestinal cells, lymphoid cells, and bone marrow. It does result in severe diarrhea, dehydration, pancytopenia, and sepsis. Fecal shredding occurs before clinical signs develop, and infection is through fecal oral contact. This virus is extremely stable, so the worst part about this disease is that your most likely young puppy is going to show it before actually having clinical signs. So it can be shed through their fecal samples. For clinical signs, usually it's lethargy, anorexia, vomiting, small bowel diarrhea in unvaccinated animals. And then to diagnose it, you can do in-house fecal antigen ELISA, which is the most common, or viral PCR. So most of the time, if you do see this as like asking what type of diagnostic you need to do for parvovirus in canines. It's typically the antigen ELISA. So if that shows up on the exam, that's honestly what I'm going to put. But to treat this, we can send the animals home. But usually we do hospitalize and do IV fluid therapy, antiemetics, and antibiotics to prevent secondary bacterial sepsis. Next step is going to be the canine constipation. So this is difficult or infrequent defecation. Delayed passing of feces results in water moving from the feces back into the body. Increasingly firm feces that are more difficult to pass. So this predisposing causes include diseases that cause dehydration, extraluminal obstruction, and colon dysmotility. And then usually difficulty posturing as well. Some clinical signs usually see straining to defecate, which is tenesmus, and then frequent posturing, passing none or small amount of dry, hard feces. And usually we can diagnose this with just clinical presentation or through radiographs. We usually treat the underlying cause if there is one present that we can see, and then also systemic rehydration and enemas. And then also after the enemas, we can do dietary fiber and laxatives at home to hopefully prevent constipation again. Next up is the canine enteric coronavirus. So this is different from the human coronavirus. This canine coronavirus can occur through exposure to multiple strains of the bacterium or through the virus. It is ingested from species that are infected with the virus and results in damage of intestinal villi, which can result in the maldigestion and malabsorption, small intestinal diarrhea. And there are certain viral strains that can affect the CNS, which can show you any CNS clinical signs. So some of the clinical signs that you can see with this is lethargy, anorexia, fever, diarrhea, ataxia, and then you can usually diagnose this by PCR. And usually the treatment is symptomatic, and there is a vaccination available, but not typically offered unless you're in an area where it's common to have this. So this is another big one that we see very commonly, which is the dietary indiscretion of dogs. This is usually commonly seen in young animals. It includes eating both food and non-food items. The consequence depends on the nature of the substance that they eat. It includes toxin exposure, gastric upset, and gastrointestinal foreign body obstruction. But some clinical signs of this that you could see is anorexia, vomiting, diarrhea, and signs related to a specific toxin ingestion. To diagnose this, usually we get it from the history that the owner presented us with, abdominal radiographs, abdominal ultrasound to identify the obstruction. And then usually to treat, we do supportive care unless the GI obstruction requires surgery to remove it. The next up is esophageal obstruction. This occurs when food is unable to move through the esophagus. It's frequently due to the presence of a foreign body that is too large to pass through the esophagus, but it can also be due to a stricture. So there is prolonged foreign bodies that can lead to pressure necrosis and esophageal perforation, aspiration pneumonia, and pleuritis. Some clinical signs for esophageal obstruction is pronounced swallowing effort, hypersalivation, pain, or mass on external palpation. And then to diagnose this, we can do a contrast X-ray, endoscopy, fluoroscopy, and then to treat, we can do like surgical removal or correction. The next step is going to be the esophagitis. This is inflammation of the esophageal mucosa through chemical, thermal, or traumatic damage to the mucosal lining. There can be chronic inflammation that can lead to structure formation, ulceration, or perforation. There are medications, corrosive substances, esophageal foreign bodies, and gastroesophageal reflux, which are predisposing causes. Some clinical signs. It's usually pretty nonspecific, but it can include like increased swallowing or effort when swallowing, retching, vomiting, air licking. So I don't think this is honestly going to be on the exam just because there's so many other things that could be tested on the veterinary license exam. But to diagnose this, you can do just a scope of the esophagus. And then to treat, you can decrease gastric acid secretion using like omeprazole and mucosal protectants like sulfurate. And I'm pretty sure this next one is going to be on the exam in some way. It's exocrine pancreatic insufficiency that we see in dogs sometimes. So this occurs when the pancreas is unable to produce digestive enzymes, is most commonly secondary to pancreatic acinar atrophy, but can be secondary to fibrosis from chronic pancreatitis, pancreatic neoplasia, or hypoplasia. So usually we see a lack of digestive enzymes, which result in malabsorption and intestinal dysbiosis. Some clinical signs that we can see with this is weight loss, polyphagia, and to diagnose it, we can do what is known as a TLI, which is the trypsin-like immunoreactivity. And then to treat, you can do a replacement with a low-fat diet and supplement cobalamin. So next is going to be the pancreatic adenocarcinoma. So this is the most common neoplasia of the canine exocrine pancreas. So this one may be good to know for the exam. Inflammation that clinically represents pancreatitis, necrosis, and fibrosis lead to bile duct obstruction. And then some clinical signs, it's pretty non-specific again, but the only way to diagnose it really is to do a biopsy. Then usually for the pancreas, we don't really do that much. We really can't. It's usually palliative therapy, and then it's usually a poor prognosis. And GDV is most likely going to be on the exam again, and it could be a question about how do you image for GDV to diagnose it. So GDV is basically it occurs when the stomach becomes gas distended and bloat, and the pylorus rotates along the longitudinal axis, which leads to gastric wall ischemia. So it compresses the caudal vena cava and portal vein, which causes hypovolemic shock, which is definitely not good. This is a very common emergency case that you see in veterinary hospitals. And some clinical signs that you can see, the number one thing that you will see is bloat, which is the abdominal distension. You can see collapse. And to diagnose this, you do a right lateral radiograph to identify the rotation of the pylorus. And to treat, we usually just do emergency derotation, and surgery and shock treatment can be used as well, which I didn't know about the shock treatment. The next step is going to be the canine foreign body. This one I commonly see in large breed dogs. This can result in minor signs such as gastroenteritis or intestinal obstruction. So this results in intestinal fluid accumulation and luminal distension, oral to obstruction, then usually ischemia is seen. Linear foreign bodies are usually typically seen in cats than in dogs. So this can cause bunching of the intestines and damage to the actual mucosa. Then for clinical signs, you can see anorexia, vomiting, diarrhea, lethargy, depression, and abdominal pain. But to diagnose a gastrointestinal obstruction, you can do radiographs, an ultrasound, or you can do exploratory surgery. And then to treat, surgery again, or endoscopic removal. And then next up is the gastric neoplasia. So this occurs uncommonly in dogs, and the most common one in dogs that you could see is the gastric adenocarcinomas. The etiology is unknown and signs are nonspecific. Usually there's a blood loss anemia that can occur. Then diagnosis again, just imaging, radiographs, ultrasound, endoscopy. But to really definitively diagnose it is biopsy. So if the question on the NAVLE comes up and asks what is the definitive diagnosis for something like this, typically biopsy from what I've seen so far with all of my studying. And then to treat, it really does depend on what type of neoplasia you're working with. And it may include surgical correction and or chemotherapy. Or gastrointestinal ulceration. This occurs when disruption of the protective mucosal barrier results in damage to the gastric or intestinal mucosa from contact with acidic gastric secretions. And the duodenum are usually the most effective. High-dose NSAIDs are the most common cause in dogs due to inhibiting the protective prostaglandin production of the stomach. So usually we would see vomiting in these cases, plus minus blood, and then also melena and dehydration and anemia. So melena, I believe, is mainly from the small intestine. So if you ever see like a dark color of blood, usually that could indicate melena. And then to diagnose it, you can do an endoscopy with a biopsy. And then to treat, you just treat the underlying disease that's causing the issue. And then you can use proton pump inhibitors and gastroprotectants. And then next up is acute hemorrhagic diarrhea syndrome. So this is characterized by sudden onset of hemorrhagic small intestinal diarrhea, hemoconcentration, and vomiting. The etiology is unknown, but clinical signs are due to increased vascular permeability of the mucosal lining and enteritis. So there is one bacterium that may be a contributing factor in this, which is Clostridium perfringens. And the clinical signs of This is acute onset hemorrhagic vomiting, bloody diarrhea, and rapid severe dehydration. For the diarrhea, you can diagnose this basically just as what you see on clinical presentation, and the hallmark of a ADS, which is the acute hemorrhagic diarrhea syndrome. You can see an elevated PCV. And then abdominal imaging is usually needed to rule out GI obstruction. To treat, we can do fluids, antiemetics, and antibiotics if there is a current fever. So that is kind of what this is. I'm not entirely sure that's going to be on the exam, but it might be. But the next one is going to be hepatic cirrhosis, so liver cirrhosis. This is the end stage of many liver diseases, which can include chronic hepatitis and copper-associated hepatopathy. In hepatocyte injury, death is followed by diffuse scarring, resulting in liver failure. There are clinical signs that can be related to signs of decreased hepatic function. Some clinical signs could be ascites, anorexia, weight loss, polyuria, polydipsia, jaundice, petechiae, seizures, and ataxia. To diagnose this, we can do liver function tests, but the only definitive one is a liver biopsy. I've kind of found with a lot of the liver diseases, the most definitive thing is to do a liver biopsy. And to treat the cirrhosis of the liver, you can do liver support with some medications, and then treat the underlying cause if you can. And with hepatitis, there is usually an idiopathic cause. There's a number of things that can cause this, anywhere from like medications to toxins or immune-mediated diseases. Some clinical signs increase with severity of disease. So you can see anorexia, weight loss, vomiting, diarrhea, jaundice, and lethargy. Usually to diagnose this, we see an elevated serum liver enzymes, which is the ALT, GTT, AST, and bilirubin. But again, a biopsy is required for definitive diagnosis. And to treat, you treat the underlying cause if possible, and you can do supportive medications as well. So it's very close to what the cirrhosis liver is like. But this one is definitely going to be on the exam. It's the salmonella in canines. So salmonella is a gram-negative rod that most frequently infects dogs through ingestion of contaminated food or water. So typically with our raw diets, we will see this. Salmonella attaches to and damages the intestinal lining. Infected animals display a range of clinical signs. Then there is a zoonosis potential with this too. So if you know anything about the NAVLE, they do like including questions about public health. So any zoonotic disease potential, usually that will show up on the exam some way. And salmonella is just one of those big ones that affects a lot of different animals. But usually with salmonella in canines at least, we will see potentially a fever, usually a hemorrhagic diarrhea and pale mucous membranes and collapse. And then to diagnose salmonella, we can do a fecal culture. To treat this, usually the mild cases are self-limiting, and the severe cases usually require IV fluids and supportive therapies, and sometimes even antibiotics. It really does depend on how severe the infection is. Next up is the cryptosporidiosis. So this is the most common, and it is a protozoa that is acquired through ingestion of contaminated feces. Usually it is ingested oocytes that insist in the intestinal epithelium, and in most cases result in asymptomatic or very mild clinical signs. So this is also a zoonotic disease, so this is another one to put on your list of potential test questions. Some clinical signs of this, usually you can see a weight loss or small bowel diarrhea. And then to diagnose it, usually you can see the cryptosporidium on a fecal flotation, a fecal PCR, or an ELISA test. And usually to treat, you just do supportive care, which is correct the dehydration and manage the diarrhea. So next up is the campylobacteriosis, which is another zoonotic disease. And this is a gram-negative rod bacteria that infects dogs through the fecal oral ingestion. And then usually uncooked meat products are a common source of infection. So if you say like a client comes in with an animal that has diarrhea and dehydration, maybe a fever, you really do want to be super careful because it could be a zoonotic potential parasite that you could get. So always make sure to do the proper PPE and definitely know this stuff for the NAVLE exam. But Campylobacter honestly is very similar to Salmonella. I believe the only difference between the two is that Campylobacter can be through certain uncooked meat products. I don't know about all of them. So just might need to know the difference between the two and how to like effectively treat them because they're diagnosed the same way. And usually you're just doing fluid therapy as well for these animals. Next up is going to be the inflammatory bowel disease, which is IBD. This is an idiopathic condition of the small intestines. Some potential causes include intestinal dysbiosis or immune dysregulation in response to ingested antigens. So a low cholabamine is commonly seen. And then some clinical signs, you can see a weight loss and intermittent diarrhea and vomiting. Still, the biopsy is the gold standard to test for IBD, which in a lot of intestinal diseases such as the liver, it's usually biopsy for some reason. That's the definitive diagnosis, unless you're looking for parasites that can show up on fecal samples. But to treat IBD, we can do a hydrolyzed or novel protein diet for the animal, and also do prednisone and probiotic supplements and cobalamin supplementation as well. And intussusception, I have not really seen this in dogs as much as I have in cats, but it's good to know it either way because I believe we treat it the same way as we do in cats. So intussusception is basically the telescoping of one section of the bowel in the intestinal tract with an adjoining segment. So this can be like due to a high parasite overload is what I've seen them happen on, and maybe potentially even a foreign body could do this as well. But telescoping essentially compromises the blood flow and can cause intestinal obstruction by itself. Some clinical signs of this is diarrhea, vomiting, lethargy, weight loss, abdominal pain, and a palpable abdominal mass. So diagnosis, usually ultrasonography is the preferred imaging technique, but you can do contrast radiography. And then to treat it, usually you have to do surgical reduction and also do like resection and anastomosis to treat the issue. And then, of course, definitely treat the underlying cause of this because usually it doesn't just happen on its own. Usually there's some underlying disease. So next up, we've got pancreatitis. And this is kind of a common thing to see. I think I've seen it mostly in schnauzers. But this is an acute or chronic inflammation of the pancreas. It can result in leakage of active digestive pancreatic enzymes, increasing necrosis of the pancreas and surrounding tissues. So some inciting causes can be high fat diet, hypertriglyceridemia, and small intestinal diseases. Then acute pancreatitis typically consists of severe signs, while chronic pancreatitis is more milder. So usually with this, we'll see vomiting, abdominal pain. You may see that weird position where the animal stretches out and their hind end goes up. Forget the name of that position, but I've seen that very commonly in pancreatitis issues. So to diagnose this, you can do an ultrasound or you will see an increased CPL value, which is blood work. And then to treat, you can do fluid therapy, antiemetics, pain control, and do a low-fat diet. And then this is definitely most likely going to be on the exam. It's the portosystemic shunt, so PSS. So these shunts are aberrant vessels that divert blood from the intestinal tract around the liver and into systemic circulation without filtering toxins, which results in hepatic encephalopathy. So we can see ammonia accumulating, which is definitely not good. It can be intra or extrahepatic, as well as congenital or acquired. I believe the congenital is more common, and also most likely on the exam, I'm going to have to know the difference between intra versus extrahepatic. So I'm going to have to look that up. But some clinical signs of PPS is poor growth, ataxia after eating, cortical, blindness, seizures, vomiting, and diarrhea. And then to diagnosis, you can do a CTA, which is the CT scan. And then to treat, you can do surgical occlusion, treatment of choice, and then medical management for poor surgical candidates, which can include low protein diets, lactulose, and antibiotics. If anyone who's watching has any questions, just let me know in the live stream area, and I'll be happy to answer this for you. But I'm just currently going through some flashcards, and I usually verbally say them out loud just because it helps me to remember what I've looked at. But next up is hepatic encephalopathy. So this occurs when hepatic function is severely impaired, resulting in hyperammonemia and circulation of other nervous toxins, which are normally filtered by the liver. So systemic circulation of these substances results in the nervous system dysfunction. And the most common cause of hepatic encephalopathy in dogs is the portosystemic shunt, which is what we just talked about. And then the diagnosis, there's really no single lab test. Usually there's abnormal liver function tests, hypoalbuminemia, liver biopsy is usually the more definitive, but again, there's really no single lab test for this. And then some clinical signs you can see with hepatic encephalopathy is ataxia, seizures, weakness, circling, and blindness. And then to treat, you can do an enema and antibiotics to decrease the bacteria. And then you can do lactulose and low protein diets. All right. But I have officially gone through 43 of my flashcards. I have quite a few more to go, but honestly, I still have about 7 weeks before I take my NAVLE, which is kind of a scary thought, but everything's gonna be fine. But I do hope you guys enjoyed this short study session. This is typically what I do on a daily basis, is just 1 hour of my time in a single day that I just sit down and study for the exam. It's been kind of hard to do that just because of my work schedule, but I've been trying to make do. I greatly appreciate that you're all here to watch this live stream, and for those of you tuning in after, again, if you do have any questions at all, feel free to let me know, and I will definitely be happy to help answer those questions. I'm just going to stay on for the next few minutes, so if there's any questions that show up in the chat, I'll answer those before I go. Thank you again so much for watching this video. If you did enjoy it, and if you did get some good study tips, and if I forgot something, please let me know down below. And I hope you all have a great day, and I will see you next week.